Okay, so we will be doing Osce today. Now, Osce has basically a written section, a performance section, and an oral section. The oral section usually involves consent taking, breaking bad news to patients. For it also involves the history taking. That's for the oral section. The performance section commonly involves doing examinations, performing a task, such as passing a urethral catheter, doing a digital rectal examination. Why the written section commonly is more like an essay kind of short question and answer format. That's basically how your Osce comes, basically. Now, there's also the picture text of it within Osce. We start by looking at some picture text, and then maybe we may go into the other sections partly today. I don't know if the slide has moved.
One more do class together.
Has the slide moved?
Yes, doctor, but it looks like two different.
Sorry? I can't hear you.
It looks like two different screens.
Okay. Right. Has the slide moved to the next page?
Yes, it has.
Okay. So now this Osce it's a seasonal level medical student examination that I drafted here precisely for investment project teaching us with the medical school. Now this picture below of the large bowel shows the vascular supply to it, and like I told you, Osce can come in form of written. It can also come. It could also come in the form of oral section where you're expected to take history taking, answer some questions, and can also come in the form of performance station. This is more of a written section. And this picture is a cross section of the blood supply to the large bowel. Now, the large bowel has some peculiar supply. The supply is usually from the superior mesenteric artery and the inferior mesenteric artery. Superior mesenteric artery supplies the right colon and half of the middle colon. The inferior mesenteric artery supplies the left half of the middle colon and then the entire colon on the left. Having said so, there are basically three branches of the superior mesenteric artery. The ileocolic artery, which is this one I'm pointing here, the right colic artery, and then the middle colic artery. The inferior mesenteric artery, which is this one here, has a left colic artery and sigmoidal artery. So they basically label the various arteries and then they ask you to label it. Now, if I were to go by that, although this picture is not very clear here, if you have to go by that, the A will be the middle colic artery. The B will be the right colic artery, and the C will be the ileocolic artery. The D will be the inferior mesenteric artery. The E will be marginal artery of Drummond. The F will be the superior mesenteric artery. The G will be the left colic artery, and the H will be the sigmoidal artery. Am I communicating?
Doctor, please, can you come again?
Okay. Now, the A is the middle colic artery. The B is the right colic artery. The C is the ileocolic artery. The D is the inferior mesenteric artery. The E is marginal artery of Drummond. The F The F is superior mesenteric artery. The G is left colic artery, and the H is sigmoidal artery. This is the blood supply to the colon. Am I communicating?
Yes, doctor.
Okay. So the next question is, what's the clinical significance of the marginal artery of Drummond? Now, the marginal artery of Drummond is an end artery. What's an end artery? An end artery is one in which its supply, it supplies a part of a tissue that does not have collateral supply. That's an end artery. So an artery that has a supply for which that tissue does not have collateral supply is an end artery. That means in event of injury to that end artery, that part of the tissue which is supplied by the artery dies off. So an injury to the part of the colon supplied by the end artery will lead to demise of that part of the colon. That is clinical significance. Are we together? Are we together?
Yes, doctor.
6 ways to identify a viable bowel at surgery. They may not ask you 6, they may ask you 2 ways. That 6 ways may just be too much for you. One, we look at from in anything, medicine, surgery, O&G, whatever it is. That's why it's in the medical practice. If they ask you to discuss something that involves examination, looking at, always start with inspection, palpation, percussion, and possibly auscultation if there is anyone. Now, if I have to look at the bowel, a viable bowel will be pinkish in coloration, right? That's when you look at it, to be pinkish in coloration. Then if you palpate it, you can feel the arterial blood supply. You could feel the position of the arteries around its margin. That's another way of identifying that this bowel is viable. That's under palpation, right? Once you make an incision over the bowel, you will see bright red blood. Once you make a nick on the bowel, you see bright red blood coming out from that point of nick. That tells it is viable. Right? Once you apply warm compress, a warm towel over it, it will become red, it will become more pinkish or reddish. That tells that bowel is viable. If you inject a dye to the patient, you see it in that point where you make your nick. That tells you that bowel is viable. So all these are some of the things you can.
Sorry, doctor, can you repeat that last one again?
If a dye is given to the patient, you will see it in that point where you make your nick initially. You see the dye in that point. That tells you that bowel is viable. These are some of the ways you could identify that this bowel is viable. Next slide. Now this question says define the structure in the image. Again, this is a stoma, right? Now for surgery, the part where you see a stoma tells you what stoma it is. Now if you see a stoma on the left, right? If you see a stoma on the left part of the patient's body, particularly on the left iliac fossa, right? They are dealing with it. That stoma is called the sigmoid colostomy. If you see that same stoma in the right iliac fossa, it's called an ileostomy. If you see that stoma in the right hypochondrial region, it's called a transverse colostomy. So the location gives it away. Am I speaking in a way that you understand? Hello?
Yes, you are. Please tell us the second one again. I didn't get the second one.
Okay. If again, this is stoma first, right? The type of stoma, if you say stoma, you may get 1 mark. That's not the complete answer. But the fact that you know it's a stoma is very important. But then what type of stoma it is it's what the location will tell you. So we see a stoma on the left iliac fossa, right? This region. It tells that that stoma is called a sigmoid colostomy. If you see that stoma in the right iliac fossa, that tells that that's an ileostomy. If you see the stoma on the right hypochondrial region, that tells you that is a transverse colostomy. Are we communicating?
Yes.
Okay, so that is that. So the structure in this image is a sigmoid colostomy. That is the structure in this image, sigmoid colostomy. Okay. So classify the pathology. Now you know that this is a sigmoid colostomy, right? Then how do you classify it? To classify a colostomy, you can either classify it based on the duration In that instance, a colostomy can be classified as temporary colostomy or permanent colostomy. A temporary colostomy is one in which it's applied, but with the plan of eventually taking it down. For a permanent colostomy, it's one in which it's applied and with that intention of taking it down. Now, the very common type of permanent colostomy is what we call end colostomy, END, end colostomy. Okay. Are we together?
Yes, we are.
Okay. So one classification for these pathologies based on duration, where we could say it is temporary or is permanent. Another classification is based on the anatomical structure involved, where we could say once if the sigmoid colon that was used for the purpose of creating the colostomy, it's called a sigmoid colostomy. If it is a transverse colon that was used for the purpose of creating the colostomy, it's called a transverse colostomy. If it is the ileum that was used to create the colostomy, it is called an ileostomy. If it is the stomach that was used to create the colostomy, we call it gastrostomy. If it is the jejunum that was used to create this colon, to create the stoma, it's called a jejunostomy. Because the colostomy can also be classified based on the continuity of the various parts, where it can be classified into loop colostomy, divided colostomy, and end colostomy. Loop colostomy is one in which the proximal and distal loop limbs are partly in continuity. What that simply means that the incision is made on it's made on the colon, but not completely through, not divided into two, divided into half, then it's extruded out. That's a loop colostomy. Divided colostomy simply means that the large colon is divided into two parts. Then how it is brought out is now what is now that divided colostomy can then be further divided into divine and double barrel. Divine is spelled as D-E-V-I-N-E. That can be your MCQ question. Divine is spelled as D-E-V-I-N-E and not D-I-V-I-N-E. Okay. Divine colostomy again is spelled as D-E-V-I-N-E, divine colostomy. Okay. So for the ovarian colostomy, the two limbs are brought out close to each other, like kissing each other, close to each other. For double barrel colostomy, the two limbs are brought together, like kissing each other. The two limbs are close to each other. Why for divine colostomy, there's a breach of skin between the two limbs, separating the two limbs. Maybe subsequently, if I have a picture, I will show you. Why for this is a loop colostomy, this one end, the other end is somewhere here. They are together. For end colostomy, one of the limb, usually the proximal limb is brought out, and the distal limb is situated inside the abdomen. So just only only one part of the intestine that comes out of the patient, but the other part is situated in closed. Usually the distal limb is closed and then left inside the patient body. That's an end colostomy. Commonly, that is usually done for when a colostomy is planned for as a permanent procedure. they may not ask you several indications, they may ask you 2 indications for the use of this colostomy. One, it's usually used to commonly used to decompress bowel in congenital conditions such as his-prong disease. Can also decongest bowel in congenital conditions such as congenital anorectal malformation. When one does surgery, usually like in the rectum, one can do a colostomy to protect your anastomosis. Depending when it heals, before you can close it, before you take it down. Once there's also an injury to the anorectal region, severe injury that so severe, one may do a colostomy to allow healing to take place. Also, once there's a tumor, a distal tumor, one can do a colostomy to decompress also. These are some of the indications for a colostomy. Now, what are the complications of this?
Sorry, quick question.
Okay, can we see them again?
Can you repeat them again? Sorry.
For
Okay,
divided, there are 2 types. What's the first and second? The one is divine and the other one is what?
double barrel.
Okay.
So the complications again, like we said, so the indications again, like we said, can be congenital indications, can be acquired indications. The congenital indications for the set for creating a colostomy will include, but not limited to, 1, to decompress the bowel in his-prong disease. 2, to decongest the bowel in conditions such as anorectal malformations. Acquired conditions could include protecting a distal anastomosis. That means someone has done a surgery, let's say for instance, is rectum, and then you don't want physics to be passing through to break down your repair. You can do a colostomy above, far above that repair to protect the anastomosis, to protect that your repair so that it will heal before you can then take down the colostomy. Also, there's severe trauma to the perineal and anal region. You can do a colostomy to allow for healing around the anal region. Again, if there's a distal tumor preventing feces from passing, you can also do a colostomy to divert feces and decompress bowel. These are some of the indications for use for setting up a colostomy. Now, some of the complications of colostomy could include 1, this colostomy could start protruding out. That's called protrusion. It could protrude out. That means the bowel could be coming out from that coming out from the patient's abdomen. So one of the complications could be protrusion. Also, even this colostomy can retract back into the abdomen, and that's the second complication called retraction. Also, some part of the other limbs inside the abdomen could get trapped around the margins of the colostomy, causing peristoma hernia. Also, to the lumen around this colostomy can get thinned out, and in that instance, a stomach stenosis could result. So these are some of the complications. Also, the stomach could get ischemic and stomach necrosis could also occur. That's one of the complications that may also occur from cyclic colostomy. Is there any questions?
Doctor, you said the lumen around the colostomy can do something leading to stomach stenosis.
Come again, please.
as one of the complications, you said
Okay.
lumen around colostomy
Okay. The lumen can get stenosed.
something. I didn't get.
The lumen can get stenosed. That means it will thin that and get
Okay.
stenosed, so that feces may not be able to come out very easily. So stomach stenosis is one of the complications.
All right, doctor. Thank you. You said other limbs can.
Okay, the limb could get retracted into the abdomen. So stomach retraction is one of the complications. The limb could pull out of the abdomen into the exterior further. That is stomach protraction, retraction. So these are some of the complications. Okay, can someone describe this lesion for me?
Isn't like a subdural hematoma?
No, that's not to describe lesion.
Oh, how to describe it? It's a the first one is a crescent-shaped lesion. Am I right?
Like, just finish your face. Just finish up.
I don't know if I'm right, but I think it's a crescent-shaped lesion. That's all I have to say about the first one.
Okay, and Shukura, could you try to describe this slide?
Okay, doctor, you said we have to describe in a pattern, either
Yep.
from inward, outward, or outward, inward.
Yep.
So I'll say that there are no fractures,
Okay.
but I can't describe the lesion.
Okay. Okay. First of all, if you're asked to describe anything that involves radiograph, okay, the first thing you want to first of all say is, in the instance they will not say describe this radiograph, they will just give you say describe, right? You first look at it properly, right? Most times, the ones you'll be given many a times, or not all the time anyway, may have names on it, written on it. It may have sex written on it. It may have age written on it. It may have hospital number written on it. So once you see the source slide, the first thing you do is take your time, look at for all these features, because all this has marks. So you look at it, and then you then say, okay, make up your mind, is this a CT scan, or is this an X-ray, or is it an MRI? For this picture, it's a CT scan. So once you make up your mind on that, you then start that this is a CT scan of, let's say, John Phillips, for instance, which is, if a name is written on it, a 36-year-old man with hospital number 1, 2, 3, 4, 5, 6. If it is written there, or if it's not written there, fine. If it's not written there, you don't mention this. Sometimes the date at which it was taken will be written there, taken on the 14th of January 2034. If it is written there, you say these are marks. If it's not written there, forget about it. Having said that, there's something I also miss. Is this an axial CT scan? Because it could be corona, it could be so this is an axial CT scan of, let's say, let's say John Phillips, okay, a 34-year-old man with hospital number 1, 2, 3, 4, 5, 6, 7. The next thing is penetration with good exposure. Next thing is exposure with good exposure and good penetration. You've now started describing the lesion, you've already started scoring marks with good exposure and good penetration. Having said that, the next thing you can then go systematically, either from inward outward or from outward inward. You don't go zigzag. You then say the bony structures are intact. Don't say there's no fracture. If there's fracture, you see. There's no fracture, see the bony structure are intact. Right? The left hemisphere reveal no pathology. However, the right hemisphere revealed a ring-enhancing lesion with perilegional halos. That is your description. Are we communicating? So that gives you a complete description.
Describe the right lesion, right hemisphere.
There's a ring-enhancing lesion with perilegional halos. Last Osce we did, I gave you subdural hematoma. Unfortunately, I lost that video because my system had issues. I took it for repair and then the man damaged my hard drive. So all my files, both the ones I prepared for previous lectures in the past, I lost all of them. Yeah, this it's just that this particular slide, fortunately, is my old system, but so I was able to retrieve this one, but the other ones I lost them. So this
that really has a lesion with peri.
Okay. So description of this stuff again is this is an X-ray, right? So this is an axial CT scan of a patient, has good penetration and good exposure. Bony structures are normal or are intact. Bony structures are normal. Left hemispheric structures are normal. However, the right hemisphere revealed a ring enhancing lesion with perilegional halo. Are we communicating?
Yes, you are.
Okay, so that's how you describe this CT scan. Now, this may come out in your exam and people will feel because what people are used to is epidural hematoma, subdural hematoma. This is another one that could come outside. Then 3 differentials of this. Number 1 differential is brain abscess. Number 2 differentials is glioblastoma multiformis. Number 3 differential is metastatic brain tumor. Then the next question is, if it belongs to a 45-year-old Fulani cattle rearer presenting with fever, worsening headaches, and vomiting, what is the most likely diagnosis? Now, the answer to this answer is brain abscess. Identify the areas marked 1, 2, 3. 1 is periregional halo. 2 is ring enhancing lesion. Is ring enhancing lesion. This is the 3 is a hypodense core. I come again. 1 is periregional halo. 2 is a hyperdense ring. 3 is hypodense core. Other investigations that you could do to confirm your diagnosis could include a blood culture. Blood culture commonly will help you to confirm your diagnosis. But most times, many times, you will not grow any organism. Okay, can someone can someone describe how you examine an anterior neck mass for me? Briefly.
All right, so for anterior neck mass, you it's like performing a thyroid exam to check for goiter, right?
Okay, question could come straightforward. Do a goiter examination. Question could come anterior neck mass. They all the
Okay,
same
so
thing.
in this case, the patient will be there, right?
Yes, for in this case, the patient will be there, but sometimes they may just tell you to verbally explain.
This exam is done in a sitting position, right?
Okay.
So we'll start the exam by telling the patient to sit down. I mean, ignoring the beginning part of greeting the examiner. So you tell the patient to sit down and you inspect. During the inspection, you check the shape, the size, you check the swelling, you note the number of swelling in the anterior neck.
Come again, please. I was not hearing. Come again, please.
I said the first thing you do is to do inspection, and then you will squat in front of the patient, right? So that you can get good vision of the swelling. Then you check the shape, you check the size, you also check the skin on the swelling. You check the number of swelling also, like you check if it's a solitary one or if it's more than one. And then you ask the patient to open their mouth, to bring out their tongue, and you check if the swelling moves with the tongue protrusion or not. So for example, if it was a goiter does not move. So you can tell that it's not a tongue, it's not a goiter if it moves. Then you do palpation. For palpation, you do, you check the temperature, you check for tenderness, you check, I think you also check the position of the trachea. You check, I think you check the size too. For palpation, you check the size too. So after the palpation, I mean, to do the temperature, you touch the mass, and then you touch the normal skin, maybe on the arm. Then for tenderness, you touch the swelling. You then ask the patient if it hurts or not. For the tracheal position, you do it like the one in respiratory exam. You put two fingers, one each, no, the index and your ring finger, each one of them will be on the, what's this thing called? Like the jugular notch, right? So the middle finger will be doing the palpation of the mass, of the trachea rather, to check if it's to check the direction. Then from there, you do, you go behind the patient, you tell them, you tell the patient to swallow again. You check how the mass is moving. You check if it's moving upwards or if it's just staying there. So basically, you do all these. Then I think you check the you check upper limb and you check the lower limb also. Are you still there?
I'm listening.
Can you hear me? Okay, so for the hand, for the upper limb rather, you check for, I think, proximal weakness. You tell the patient to do, before this one, you still do you do percussion. It's just the upper chest. You do the percussion of the from the sternum and upwards. You also do auscultation with the scalp, and then you do a lot of examination for the eyes. You check for exophthalmos. You check, there are a lot of examinations in the eyes, but I don't really know their names, but it's the one that you do like an H. Then you also do upper limb examination. You tell the patient to put his hands, say, for example, to comb his hair, you check for finger clubbing. What else do you do? You do lower limb also. For the lower limb, you can tell the patient to squat and tell him to stand up without using his hands. Then you check for myxedema around the pretuberal region. You check for ankle reflex also. I think that one you supinate the ankle and then hit it at the back to see for the reflex, to check for the reflexes. I think that's most of the things that I would do.
Okay, so is there any corrections we need to that we notice that we need to correct?
Is that a question for me?
Yeah, I'm asking Rhoda, Shukura, is there anything you need to make corrections on?
No, Doctor, I didn't.
Sorry?
Okay,
I can't hear you.
I think it's fine.
How
I
about
think it's
Shukura?
fine.
Okay, how about Shukura?
I think you did well as well.
Okay, well, from one point of view, you did well, but it's not sequential, you get. And for if it's for the exam, you've passed to, but you will lose marks for orderliness, you get. Now, how it starts from thyroid examination starts from the front, proceeds to the back, then you move to the front again, and then you thank your patient, you go your way. That's how it moves from the front to the back, the front, and that's all. So in the front, what you do is you inspect the patient. Usually the patient is on a seated position, right? You inspect the thyroid gland, you look at it very well. You should be seen squatting to the level of the neck. You look at the neck, like you said, look for multiple masses, right? You look for skin changes around the thyroid gland. Having done that, you check for differential warmth. And how you check for differential warmth is this way. You start from normal skin to diseased skin to back to normal skin. That's the sequence. From normal skin to the thyroid gland and back to the normal skin. And not from the diseased gland and to the normal skin. You want to have the temperature of the normal skin, then compare it to the temperature of the diseased skin, and then go back and compare to be sure that what you have is in keeping with what you had in your mind, keeping with what you found. So you start with the normal skin, diseased skin, and normal skin. So in this instance, from the normal skin to the thyroid gland and then to the normal skin, you do mild palpation for tenderness. You palpate both lobes mildly for tenderness. I haven't skipped one. Okay, let me come again. I skipped one. The first instance, you look at the tumor, right? You look at for skin changes, number of nodules. Then at that point in time, commonly, there usually will be a glass of water by the patient's side. You should watch out for that. You tell the patient to take the glass of water and drink. In the absence of that, you could tell the patient to swallow. But before that, you tell the patient to stick out his or her tongue. When you stick out your tongue, you look for movement of the thyroid gland. A thyroid mass, right, should not move when the tongue is protruded out. But a thyroglossal duct cyst will move. Am I communicating?
Doctor, this excuse me, this sticking out tongue, is it do you do it after the drinking water, or is
No,
it
it's before.
Okay.
It's before you stick out the tongue first. After sticking out the tongue, then you then tell the patient to drink water. Then after that, you then go for feeling for differential warm tenderness. Then if you have your measuring tape, you could measure the gland at that point in time. After that, you then feel for trachea deviation. How you do that? You place your two hands on the clavicular notch, and then you place your index and ring finger on the clavicular notch, and then your middle finger on the trachea, and then you roll it down through to the jugular notch of the sternum, and watch if your hand deviates. If it deviates, it tells that there's trachea deviation. If it doesn't deviate, it tells that there's no trachea deviation. Having done this, you could then proceed to the back of the patient. When you get to the back of the patient, you then palpate the gland. You place your two hands on the gland, your four fingers on the gland, your thumb on the occiput of the patient. So by so doing so, your two hands wrap around the neck of the patient, with your thumb acting as a stabilizer around the occiput of the patient. Then you gently rub your right hand over the gland to feel for consistency. You rub your left hand on the gland to feel for consistency. At this point, again, you place your hand at the base of the neck or the gland. They tell the patient to swallow. If the patient swallows, you should feel the base of the gland. If you don't feel it, it means that there's a retrosternal extension. Then you then palpate it, you then percuss the chest. How you percuss, you go up to the level of the, for a patient that doesn't have a pendulous breast, you could go up to the level of the nipple. For a patient that has pendulous breast, you could go up to the level of just below the I guess that's the sternal joint now. Could be just below that, and then percuss upwards. You could percuss from the level of the foretrip upwards to the clavicle, and listen for differential dullness. When you get to differential dullness, that tells that may be the extent of the retrosternal extended goiter. Having done this, carry your stethoscope, place on just below the angle of the mandible. Listen for brew. Having listened for brew, you hang back your stethoscope. You then check for navsicular. Now you then do a navsicular sign where you place your hand on your four fingers now on the mandible, and then your hand stabilizing the occiput. They extend the neck. You check and place so that your eye level is at the level of the upper eyelid. If you could see the upper limbus of the eye, that is eye protrusion. That's navicular sign. Having done a navicular sign, you then palpate for lymph nodes. You can start, and you're palpating for your lymph nodes, you must be sequential. So you could start from the pre-auricular, go to the post-auricular, go to the occipital. You can then come to the submental, submandibular. And you can then go to the upper cervical, middle cervical, lower cervical, supraclavicular, infraclavicular lymph node. Once you are done with this, we then move to the front of the patient. They then perform your eye signs. You can then do the ophthalmopathy sign, where you do that your H sign to check for paraplegia of any of the eye muscles. We then do you check the various signs. I'll mention them for you. Your von Graffi sign, the Ripley sign, Stellwalk sign, and Mobius sign. So you check those signs. How you check for them? There are 4 or 5 of them. Again, the Ripley, Stellwalk, Mobius, von Graffi. I've described navsiglas for you. So these are the 5 signs you can do. You do navsiglas while you are in the behind of the patient, but these other 4 signs plus your H sign, you do them while the patient is in front of you. I don't know if you are hearing me.
Yes.
We can hear you.
Okay, having done these your signs, you then proceed to palpate the axillary lymph nodes. Having palpated the axillary lymph nodes sequentially, you then can palpate the supratrochlear lymph nodes around the elbow. Having done that, you tell the patient to stretch out the 2 palms with the palm facing down and then the dorsum facing up. We then place a white sheet of paper. You could ask, if you don't have, you could ask the examiner at that point in time, so maybe the white sheet of paper will give to you on top of the patient's hands, and then you watch for fine tremors. How do you watch for fine tremors? You squat to the level of the paper with your eye at the level of the paper, and then you watch for tremors. Having done that, we then check for finger clubbing. And then after checking for finger clubbing, we then tell the patient to expose the palm of the hand. We then inspect the palm of the hand. Having inspected, what I expected to inspect for? Expected to inspect for wetness of the palm, the sweating palm. Then the next thing you then do is to palpate the palm. And what are you palpating for? For warmness. Again, if you look at the palm, you look for erythema in the palm, wetness of the palm. So you palpate for differential warmth in the palm by placing on the palm. You check for you also examine the muscle bulk of the palm. Having done this, you could then do your cubital fossa reflex. So your bicep reflex, sorry. Or you could decide to skip that and then move to the lower limb. In the lower limb, what do? You inspect the shin for pretibial myxedema, and then you then do your ankle reflex. If you did the bicep reflex, you're going to do the ankle reflex. Having done the ankle reflex, the next thing you do is to tell the patient to get up and walk. Again, this getting up and walking is, you can actually do it before or after. How? After examining, once you tell the patient to get up and walk, and the patient comes back, so that you thank the patient, that completes your thyroid examination. However, sometimes this getting up and walking is usually done when you forget to do it earlier. How do you do it earlier? Once you've finish doing your naviglas and you palpated your lymph up to the infraclavicular lymph node, you can tell the patient to comb his hair, or you could apply pressure on the shoulder and tell the patient to shrug it off. That tells you proximal myopathy. If you forget to do this one, then at the end, tell the patient to get up and walk. That also tells that also tests for proximal myopathy also too. That completes your thyroid examination. So it doesn't mean that you must do combing at the same time. It's one of the three you do. Okay.
Yes, doctor.
Okay, so that's for this question. Then this other question. Identify this condition. Can someone attempt to answer this question?
Syndactyly.
Okay, but it's not complete, you know. So you say syndactyly, you get 1 mark. The complete answer is complete syndactyly of the third web space. Okay.
Doctor, please, can you repeat it?
Of third what?
Complete syndactyly, even complete syndactyly of the third web space. That's not even complete, you know. The answer will be complete syndactyly of the third web space of the right hand. That's a complete answer. Complete syndactyly of the third web space of the right hand. That is the complete answer. Complete syndactyly of the third web space of the right hand. That is the complete answer. What other areas of the body may also be affected by this condition? Now, you could have the chest, where you could have Poland syndrome. You could have the spinal cord, where you could have spinal bifida. You could have the heart, where you could have congenital heart defects. That's the answer to that question. So can someone answer this number 3? What single most relevant investigation will you request for this patient? Can someone answer number 3? What single most relevant investigation will you request for this patient? Can someone attempt it? Okay, the single most relevant investigation will be an X-ray.
X-ray.
Yep.
I was thinking about something more difficult.
No. That's it mustn't be that difficult sometimes. Okay, so
Doctor, please, can you read that number 2?
okay, what other areas of the body may also be affected by this condition? Now, this is a congenital condition, remember? So if it's congenital, okay, this condition can be congenital, it could be acquired. However, this particular condition is congenital. How do I know it's congenital? I can't find any scar. If there's a scar or there's a bone injury, like it's like a bone scar, we know that is acquired. But in this instance where the skin is intact, it's a congenital condition. So if it's congenital, that means associated with many syndromes, such as the Poland syndrome, the Bactrial syndrome, right? So in Poland syndrome, there's deficiency of the pectoralis major. So other areas of the body that may also be affected include the chest, where there's absence of pectoralis major. If it's part of the Bactrial syndrome, that part that you could get, that's one could also have congenital heart diseases, spinal cord defects, such as spinal bifida. It can also be associated with what we call apart syndrome, where so in this instance, it can also affect the face also too. You also see some deficiency on the face, such as an apart syndrome, where they have midfacial deficiencies. Okay. I will skip this one. This one may not. This is all about basic surgical, basic life support. Sorry, this question is about basic life support. So I'll skip this question. So can someone attempt this one? I think this is the last. So can someone attempt this one before we call it off a day? Can someone attempt this one? This 50-year-old.
I can try, doctor.
Okay, fine.
Doctor, can I try?
Yes, please go ahead.
Okay, but first let me confirm. What are we supposed to be counseling her about?
Okay. So of your findings.
Okay. Good day, examiner. Good day, patient. My name is Shukra. I'm a candidate of this exam. I've been asked to counsel you about your mammography results. Please, can you confirm that you are Mrs. So-and-so and you're 50 years old? Please, I would like to assure you that whatever we discuss here is confidential and will not be shared to anybody. May I proceed? Thank you. Are you okay with continuing this conversation in English, or would you like to switch to another language? Are you okay here, or would you like to move somewhere else? Would you like a family member in the room with you? Would you like a glass of water? Can you tell me, can I take a quick history about your disease? When did you do the mammography? How long have you had these features? What do you know about breast cancer or a mammography? Do you know somebody who has breast cancer? Have you Googled it? So breast cancer is a tumor of the breast that is of different kinds and presents with a number of symptoms. It is caused by mutations in the gene, and implicated genes include BRCA1 and 2. You are at high risk of having breast cancer if you have a family history of carcinoma, especially breast carcinoma. You are also at risk if you have these genes, BRCA1 and 2. There's no direct line of etiology to breast cancer apart from mutations with the gene and family history. There are different types of breast cancer. There's ductal carcinoma, and there's also the lobular carcinoma, and they can be caught in different stages of presentation. Breast cancer will present with a number of symptoms, including nipple retraction and peel the orange sign, which is when your breast will look like orange peel. To investigate breast cancer, there's something, we do the triple assessment, which is where we take a history, and we also do a cytology, and also we do physical examination. Now, you have done a mammography, and your mammography results have shown features consistent with ductal carcinoma, but I've also taken your physical history now, and both your physical history and your clinical history are unremarkable. That means that there's nothing pointing to a carcinoma. It could be that your mammography has presented a false positive results because of your age, which is when the mammography results, which is when the results are falsely positive, meaning they're showing you to have something that you don't. So I will recommend a repeat test, possibly a biopsy, to be able to check for abnormal cells, abnormal cells even better than a mammography can. Do you understand all I've said so far? You don't have to be scared. It's a positive sign that your clinical history and the physical examination of your breasts have shown no pathology. Whatever the case, I can assure you that we have enough clinicians and skilled oncologists here that will help you with whatever the outcome of further testing. May I go ahead and book you for further investigation and also a follow-up? Can you explain to me what you understand from what I've said? Thank you. Thank you.
Okay, well done. You answered basically. If it's an exam, I think you score very high in this performance station. But what I will need to add to this will be this. Periodically, you stop, pause, and then ask the patient, do you want more information? Should I continue? Or you're okay with this? You only did that once. You have to stop. Then in the initial or at the end, you could do this at both either initial or the end. You have any means of going home, or should I make an arrangement for you to go home? Then finally, you should tell the patient your clinic visit days. My clinic visit days are Tuesday, Wednesday. In the case you make up your mind on this, you come always see me on this clinic visit days. For this, you pass the exam. However, for the question itself, you may not get very much, because this question is a very tricky question. How is it tricky? How is it trickish? Now, the question says ductal carcinoma in the outer half of the right breast. What was very important that you answered very well, which was very, very good and very up to the point, was that the patient will need a biopsy. Having said that, if the result of the biopsy comes out that is still ductal carcinoma in situ, surgery will be recommended, and the types of surgery will include this. If you don't know the type of surgery, you could tell them that surgery will be recommended. Other treatment options include chemotherapy and radiotherapy. However, type of surgery, if you don't know, you just do that part, but that part may be very kind of postgraduate. But you could tell them that surgical the surgery is mastectomy, and there are various types of mastectomy. For the various types of mastectomy, that's the technical part you may not really know. But just know that surgery could be indicated, and surgery could be mastectomy, and there are various types. You could just skip that part. Other therapy include chemotherapy and radiotherapy. If you say all this, I think you scored maximum in this particular station. Can someone else attempt to answer this question? I think she has done very well. Can someone else attempt it? Can someone else attempt this? This is a learning curve. Let nobody be shy. Please speak up, okay? Okay, nobody is attempting to talk about it. I think that with this last slide, first of all, well done, Chukura, well done, Rhoda, well done, Frankie. And there's this other guy, I think he just stepped out now.
Thank you, Doctor.
So we've come to the end of today's section. Tomorrow, we may have 2 or 3 sections tomorrow. Community medicine will be one of it. Maybe pediatrics and surgery. For some time now, we will not be having O and G, and we may have to find a way of getting someone else to handle that part because so that will be the end of today's
Thank you so much, Doctor.